Thank you, Dr. Ndagurwa, for the presentation. So, as the chairperson for this segment, am I immune to not having any questions asked after my presentations? The world is full of snakes, ranging from harmless grass snakes to burrowing puff adders. Ladies and gentlemen, my talk is not about snakes, but it's about the cervix. And we continue to preach or remind each other on individualized care, individualized screening. So I'll be talking about cervical length assessment, preterm birth screening, and prevention. So objectives of my talk, I'll briefly talk about preterm labor, the epidemiology, the prevention mechanisms, risk stratification, the protocols for preterm birth screening, as well as a few cases. So why does preterm birth matters? So as of 2020, about 13.4 million babies were born prematurely globally, and that contributed to about 1 in 10 live births occurring before 37 weeks. And prematurity is the leading cause of mortality in children under 5 years. I want you to think of the most recent premature baby that you managed and think about how it could have been avoided. So that's where this talk will be centered on, to say, of all these premature babies that are born in a limited resource like Zimbabwe, where intensive care unit facilities are scarce, what if there is a way of reducing those rates of preterm birth? So there are 4 things. We need to identify those that are at risk. We measure the cervix, act early. That will lead to improved outcomes. So by identifying the risks, we keep going back to the first presenter. We start off with the maternal history. So for those who've had a preterm delivery before, they're at an already increased risk of having a preterm birth. But mind you, this should be individualized because they might have had a short or preterm delivery before, but pregnancies differ. So by identifying them, we have a preterm labor surveillance clinic at Salimugabe, where we see women between 11 and 13 weeks, and at that time we scan them. I'm going to talk about the protocol in the next slides. We do a transvaginal assessment of the cervix, after which we then stratify them. So for those who would have a short cervix or with prior preterm deliveries, we then start to monitor them 2 weekly. For those with severely short cervices, we then assign those to the preterm labor surveillance clinic, whom will be sending for sacrilege stitching sessions. Some will also be started on progesterone. So what is a short cervix? So the definition is that as per transvaginal measurement, a short cervix would be a cervix that is less than 25 millimeters. And those 2 images that you see on the screen are just showing one cervix is a long cervix, whilst the other one is a short one. So this is greater than 25 mils. Mind, as I'll be teaching students somewhere, we always rely on dimensions. So mind the image on the left, there's no dimension there to justify that it is a long cervix. So subjective assessment can also come with its shortfalls, hence the need to measure. So the one on the right, 15 millimeters, so that's a short cervix. So in some pregnancies, you might scan a patient, say at 20 weeks, you see a cervix like the one on the left. The reason why we then see them regularly, it's because what we don't see, you can measure the blood pressure preeclampsia, we can tell the maternal blood pressure is rising, but for the cervix, we will need to perform the transvaginal scan. So it will open internally, unannounced, and remember our goal is to reduce prematurity rates. So who's then at a high risk of preterm birth? So obstetric history, those who've had previous spontaneous preterm birth or mid-trimester loss. We know our women, they book late. So at the fetal medicine unit, regardless of the time they come to book, we then perform a transvaginal scan as baseline assessment of the state of the cervix. Then cervical history, this will comprise of those who might have cervical surgery, those with repeated dilatation, and those with uterine anomalies. So transvaginal will come in as the best modality compared to transabdominal assessment. Then current pregnancy also comes as a risk factor to say if it is a multiple pregnancy, there's also an increased risk of preterm delivery if there is associated bleeding in that current pregnancy. So allow me to take you back to this image. This color box over here also serves as a assessment to exclude a low-lying placenta and also the likes of vasa previa. So transvaginal assessment of the cervix comes as a multi-headed spear. You are not only assessing the cervix but also checking placenta or location as well as excluding any vasa previa. Then social context, short interpregnancy interval, those who might have a very short pregnancy interval, they also score high on preterm birth delivery. Smoking, low BMI, maternal comorbidity, other illnesses that the mother might be having, and in our low resource setting, limited antenatal access, which is why we also decided to come to Khumbula so that there is Gwanda, there is Nkai, so you guys here can also go on and spread whatever you are learning so that we also reduce any complications related to fetal medicine. So for the screening strategy, so if we see a patient between 11 and 13 weeks and we measure the cervix transvaginally and it's greater than 35 millimeters, that is a low risk. So that is for singletons. And for these ones, we then see them at the 20-week scan, the anomaly scan or mid-trimester scan. Then for those who will have a cervix less than 25 millimeters between 16 and 24 weeks, so this might also date back to the 11 to 13-week scan. So for some of them, we recommend a stitch, a sacrilege stitch, and then we continuously monitor them fortnightly. Now, as for the protocol, so transvaginal assessment, we perform it on an empty bladder, so the patient is asked to empty their bladder, and we then seek consent, explain the procedure in full, that it's not a painful procedure. Infection control, we also try to make sure we are performing the scan in a environment that is clean, and also chaperone. So we also need to be mindful, even if you are female, always have a chaperone in your presence when you perform a transvaginal scan. Then the patient goes into the lithotomy position and you gently insert the probe. I'm sure some of you might have had the privilege to perform a transvaginal scan yesterday. So upon gentle insertion of the probe, you achieve the mid-sagittal plane, and in that mid-sagittal plane, you should be able to see the internal os all the way to the external os. Then avoid pressure, so the anterior and posterior fornices must be of equal thicknesses. and magnify the image to occupy at least 75% of the screen. And then you measure from the internal os to the external os. And the examination time should be between 3 to 5 minutes. Reason being that if you perform it for less, you might measure the cervix. Perhaps there will be an ongoing contraction of the myometrium, which might forcibly elongate the cervix. Hence, the 3 to 5 minute window. So that image at the bottom just corresponds to where you then measure from the internal os to the external os. So you would find that not all cervices are straight. Some of them also come, they present as curved. Hence, the need to trace from the internal os to the external os. Now, this slide is just showing what might occur, as I had indicated when I started my presentation. We meet so many cervices and we worry about them shortening. So you'd find that for some patients, you might see them at 20 weeks, you see them at 24 weeks, and these cervices tend to also shorten without any predictable pattern. Hence, there is an algorithm that you can use, which is available at the Fetal Medicine Foundation website, where you take the maternal history as well as the cervix length that you'd have measured. As you then input it, it will give you a prediction to say this patient is at an increased risk of preterm delivery at 36 weeks or before 36 weeks, etc. So, for those that have a cervix that is less than 20 millimeters, there is strong evidence that vaginal progesterone would also prevent prematurity. So we've also had this evidence for the patients, the cohort of patients that we've been following up, to say those who do get progesterone and religiously use it, they also tend to go beyond 36, 37 weeks. So what are the common pitfalls when performing transvaginal assessment of the cervix? So during my training, it was common practice for people to measure the cervix on pregnant women as well as using transabdominal approach. But transabdominal approach has its limitations, which can be disastrous. Number one, an overfull bladder can forcibly elongate the cervix. Then what the bladder does, it will put pressure on the internal os as well as the external os, and then you might assume the cervix is closed. So of everything that I'm going to talk about, there's a video at the end. So please just focus more on that video. Whatever else I'm talking about, the video is the one that will summarize everything. So look forward to that one. So I was talking on the common pitfalls, and also avoid, when we are now performing the transvaginal scan, avoid too much pressure. So too much pressure can also forcibly elongate or forcibly shorten the cervix. Then wrong plane. So like I mentioned earlier, you need to measure at the level of the mid-sagittal plane, where you clearly see the internal os as well as the external os. And you might also meet funneling, where there is increased amniotic fluid pressure and the internal os tends to funnel. So you see images when I get to the few cases that I will present. So that image is a transvaginal assessment of the cervix, and you can see the thickness of this posterior fornix versus the anterior one. So this one, there was a lot of probe pressure, so you need to then retract the probe a bit so that the anterior and posterior fornices are of equal thicknesses. Then for those patients who would be indicated to get a sacrilege stitch, we then perform a transvaginal scan 2 weeks post-insertion to just check the position of the cervix, so of the stitch rather. So you would find that some of the stitches will be correctly placed and some might not be. So evidence now will impact the outcome. So the image on the left, these bright or echogenic structures, that's the stitch. This will be the internal os, external os. So what we'll be interested in is to measure the length of the cervix as I'm tracing, as well as the distance before the stitch and the distance post the stitch. So the image on the right is showing a stitch in position. However, the stitch is distally located. In some cases, the stitch might actually fail. So in some of these patients, we then recommend reinsertion. So this is a case of a 21-year-old para-O who had 2 previous second trimester miscarriages, and they had an indicated sacrilege stitch which was inserted at 16 weeks, and they came for their anomaly scan at 21 weeks. So you can see there is evidence of these membranes bulging into the cervical canal, as well as the image on the right. So why it is important to also perform a post-stitch insertion transvaginal assessment to just check the position of the stitch. Then another case, a 33-year-old para-O, 2 first trimester pregnancy losses. A stitch was inserted at 16 weeks, and again the stitch was distally located, hence the need for serial monitoring. Then for this one, 23-year-old, 2 second trimester miscarriages. Let's now focus on the images. So the first image at 16 weeks, you would see the cervix was long enough, 25 millimeters borderline. Then the stitch in position, but with serial monitoring 2 weekly, you then find shortening of the cervix over time despite a stitch being in position. Then another case of a stitch failure. So you see the cervix is now open, and then that would be a failed stitch. Another image showing a stitch which also failed. So there is evidence of funneling, a short cervix. Then these are the knots of the stitch. One is in the amniotic cavity, whilst the other one is in the cervix. Hence, the need to monitor these stitches post-insertion. Then there are also success stories whereby the cervix was funneling, stitch was inserted at 21 weeks, monitored 2 weekly, then the patient went on to deliver at term. Okay, then this was a case at the anomaly scan, routine scan. Then there was evidence of bulging membranes. The cervix was already open. Hence, again, the need for routine anomaly scan. You also add the transvaginal assessment of the cervix, and our goal is to reduce the prematurity rate. So, image checklist. So, getting a perfect image also requires a standard, like the audit that was being mentioned earlier. So you can also actually get FMF certification if you send images to them of these cervical ultrasound images. So you need to make sure that the cervix is seen in the true mid-sagittal plane. You need to be able to identify the external os as well as the internal os. And you also need to ask, is the measurement technically valid? So remember, you need to measure over a course of 3 to 5 minutes. because there are dynamic changes that would also occur. So let's get to the last slide, the one that I said will summarize everything. So this was a patient. At first you'd scan, the first minute you scan and you see a closed cervix. But over the course of 3 minutes, the cervix then started to show that there is actually short cervix with also funneling. One more time. Anyway, I'll share the slides. Right, there we go now. Okay, so conclusions and recommendations. Let's screen the women starting from the first trimester. The late bookers, at the time they present, let's also ensure that we perform transvaginal assessment of the cervix as well as perform serial ultrasound assessments. Then we can also make use of the predictive models where we enter the cervix length at the time where we scan, so that we are able to predict risks accordingly. So here are the guidelines for performing the transvaginal ultrasound from ISOG 2022. And thank you.